There is a little bit of a change in the order. The first presenter will be Dr. Jitendra Jitani. He'll be presenting on DY stereo test, calculate amount of stereopsis. Dr. Dinesh Gar and Dr. Shrikant Singh will be judging it.
Should I start? Should I start? Okay, so good morning, everybody. I will be presenting a small theorem on how to make your own stereo test, and most important that stereo tests are available, but how to find out what is the amount of stereopsis you are getting. That thing is little difficult, and how you can use your own TNO stereo test or some other stereo test for different distances, and what is the importance of this distance. So we all know what stereo acuity is. Most of us are familiar with the type of stereo acuity things available. TNO is the Netherlands organization, Titmus, Frisbee, Red Dot, and Langs. So what we have to do basically here is that we have to take a simple plain black and white image. We have to, if the judges can use their red and green glasses, they will be able to see an image. Now this has been made green free. Not very difficult. With any routine software, you can make it green free. It becomes a red image, and another image is a green image. And then what you have to do basically is you have got a black image, a red, a green, and this is the stereoscopic image. The last one is the stereoscopic image. Now, how do we, what we have done here is we have superimposed the two images, the red and the green image, and we have separated it. You can see the distance between the two images. Now, this has to be within the Panams area, and this distance we can do it on our own. Any software you just have to you have to superimpose the two images and create a distance between the two. And this is a different distance, that is a different distance. So the amount of stereopsis differs. And most of us have this problem as to how much is the stereo acuity. I mean, that is what we are interested in at the end of the day. And most of the stereo tests don't show that. So these are multiple images I have created. We can create a 3D movie with this. I will keep on clicking. You will see that the image will start coming out of that thing. Now, how do you calculate that? It is pretty simple. You have to use basic mathematics. So basically, what we have done is we have created a theorem here with which you can easily calculate what is the amount of stereo acuity. Very simple thing. And this is the final equation at 40 centimeters. If the disparity is of 1 centimeter, you get a stereo acuity of 51 seconds of arc. And then you can calculate based on this particular distance. So it depends on the size of the image and your distance from the image. So these are some of the more images. You can, we have just scanned some of the TNO images, made our own images. So these are all images you can see stereoscopically in this, and this, and this. So thank you so much. I am on time. Thank you so much. If there are any questions, we can take those questions. Yes, thank you.
It's been a nice presentation. And how do you want plan to commercialize it? Do you have a kind of a test booklet planned or done already?
No, sir. This is basically more to answer a basic science question. This was not for commercialization. There are enough stereo tests available, but the problem is that nobody has any idea. Like, we get a stereo test. Like, if we have a TNO chart, we can use it for distance also. And you can use any chart for any distance. You have to know how much the stereo acuity level is, because at the end of the day, if you are using it for a distance stereo acuity, you should be knowing कि कितना stereopsis मिल रहा है. So this is basically to define how much stereo acuity you will get. So if you have a stereo chart like TNO, which has to be seen at 40 centimeters, you just have to take that 40 centimeters, D upon 40, into the amount of stereopsis that they are saying that image has. This will give you the amount of stereo acuity at any distance for the same chart. However, if you scan that particular chart and project it, you can have a huge difference. You can make your own stereo acuity chart. A normal distant stereo acuity chart costs around 1,20,000. A normal, any ren dot or frisbee. This is like you can scan a TNO image and project it with a projector, which can cost around 5,000 rupees. Nowadays, there are pocket projectors available. You can easily do it in 5,000 rupees. So the cost saving is lot. This is not for commercialization. This answers a basic question. How do you know how much stereo acuity your chart is giving? No stereo chart tells you how much stereo acuity will be at a different distance, what is going on. Basically, it is like this chart is there, you have to use it for 40 centimeters, itna stereo acuity milega aapko.
Yeah, that's what I'm saying. But I think you can take it to a next level. Probably that is just a suggestion.
Yes, thank you,
and make a DIY stereo test or a stereo chart, which is easily commercially available at a very low cost. Yeah,
we'll do this, sir. Thank you, sir. Thank you.
Collect a certificate. The next presenter will be Dr. Atul. He'll be talking on intraocular diathermy instrument, a challenge overcome in VR surgery.
Good morning, respected judges and dear audience. So let's look at a routine case. Let's look at a routine case of advanced diabetic vitrectomy. So as you see, the membranes are being cut and then the bleed starts happening. So we have to go out, get in a cautery to cauterize the bleeder. And then again, we will take, after cauterizing, we'll take the cautery out and then we'll continue. But by the time, as you can see, the bleeding has started from somewhere else and the entire field is filled with blood. So this is how the idea began. How could I have prevented this? What could I have done differently? So I would like to present to you intraocular diathermy instrument, a challenge we have overcome in vitreoretinal surgery. So conventional diathermy probe is point shaped, as you saw in the video. The surgeon must push on the blood vessel with the probe to close it and then coagulate it. High energy levels are needed and often it leads to collateral damage. And tip of the diathermy probe, sometimes it can block the surgeon's view from the blood vessel. So you are not seeing actually what you're cauterizing because the tip can block it. And this unavoidable delay when you change the instrument can cause excess bleeding inside the eye. So this is a major deterrent in performing advanced diabetic vitrectomy surgeries. So we thought, how can we combine a membrane peeling forceps with diathermy? Can I give the membrane peeling forceps diathermy ability? So with that point in mind, we wanted to apply mechanical compression from opposite sides, at the same time giving it diathermy function, and it can also be used to peel the membrane. So you hold your membrane, cauterize it, and then peel it immediately. So how can you do it with one instrument when you are doing a 3-port vitrectomy? So we wanted a material that is conductive. It doesn't dissipate heat in the shaft of the instrument, only at the tip, and it should have good temper and hardness, and can be operated with, you can have a separate foot switch for the cautery function, or you can have a button on the handle which can cause the cauterizing ability. So with that, with the assistance of Chennai Surgicals, we have developed the first prototype. As you see here, this is a 20 gauge instrument. This works with a push button system. So the push button system closes the forceps, and there is a foot switch which can be pressed to give the cautery. So only the cautery is delivered only when it's needed. So you hold your thing, and then when it's needed, you deliver the cautery. So as you can see in the cross section here at the circles, so the outer circle and the inner circle are conducting two different poles of the bipolar cautery, and inside the white area that you see is the insulation material. So there is no contact between the outer circular cylinder and the inner circular cylinder, and each cylinder is connected to the one cylinder to one prong and the inner cylinder to the other prong. So when they come in contact with each other, the diathermy happens at the tip of the forceps. So that's the concept, and that we have developed the first prototype. So now we are going on to make 23 and 25 gauge instruments, and we are also trying to give cauterizing ability to other instruments like retinal pick. And also, as you can see in the video here, we are also working on making endolight and endolaser together, so that laser can be delivered with the endolight itself, so that one of your hand is free and you can have something else. Maybe you can indent with one hand and then illuminate and laser at the same time. You don't need an assistant, something like that. So we are working on that as well. Thank you.
Can I comment on this? Well, in 20 gauge era, we used to have the same kind of instrumentation which had a pick, an aspirator, and a light.
Yes.
In all three. So that was the original by Dr. Dijuan and Dr. Steve McQueen. But what I find, your forcep idea is good. Only thing I feel it lacks the tactile sensation and ergonomics. Because when you are peeling a membrane, you like to squeeze, have the membrane and then peel it. This is too much of a, I think that tactile sensation is rather important while peeling. Thank you.
Thank you, sir.
Dr. Gopal S. Pillai, can you ask him questions?
Excellent innovation.
Thank you, sir.
So, have you done some surgeries with it? What are the challenges that you faced while you were doing surgeries with it? Have you done some?
We have not moved into the human trials. Is way down the line.
All right.
Even animal trials, we are it's pending. We are trying to make a pig eye setup in which our team from Netherlands had did the same thing by cauterizing vessels of a cadaveric pig eye. So we are working on the porcine eye. The study is going on. But human trials are way down the line. But before that, we want to make it into 23 and 25 and then try it, because there's no point in experimenting with 20 gauge right now because that era has passed by. So, but we are making good headway, and a lot of progress has been made.
What are the challenges that you feel?
So the main challenge right now is coming onto a definite insulation material. Like I said, we have two cylinders. So the white area that you saw was an insulating material between the two cylinders. So the exact material that can insulate both these things, we are trial and error we are doing. Some material are stable, but after about 50 autoclaves, they are disintegrating. So we want an instrument that can be autoclaved multiple times and reused. So we are working on the materials, and hardness, we have almost achieved the good hardness, but this insulating material is one of the challenges we are facing right now. But we are making good progress.
Okay, thank you.
Weight of the instrument will also have some weight. How much weight that?
Yes, sir. We are trying to make it a very thin, just similar to the membrane peeling forceps we use, but definitely weight is something we should take into account.
I suggest you connect with the metallurgy department of Indian Institute of Science.
Yes.
If you spend a week there, I think they will crack the thing.
Yes, so actually there is a metallurgical department working with the instruments team. So they are working in tandem. It's just that the metallurgical people are a bit slow in their, like, they take their time.
At IAOC, Indian Institute of Science.
Okay,
Indian
sir.
Institute of Science.
Sure, sir.
The best in the world, they are there. And they are very cooperative.
Okay, sir. Thank you, sir.
Okay, the next presenter is Dr. Satyantan Ghosh on drug penetration through cornea and estimation of ocular tissue barrier, and the discussant is Dr. Sonu Goyal. Dr. Satyantan Ghosh is here. Okay. If he's not here, the next presenter is Dr. Ushma Vora to see the unseen. Discussant here. Discussant will be Dr. Raj Shekhar. Where are not available to put
and all present here. All the retina surgeons love the word retina, but they definitely dread the word recurrence. A 40-year-old patient presented to us a case of pathological myopia with diminution of vision in left eye since 4 days. The patient had undergone vitrectomy in the same eye 4 weeks back for macula involving inferior recurrent retinal detachment. On examination, the right eye was stable. The left eye vision was hand movements. She was pseudophakic and she had a recurrent inferior retinal detachment in an oil-filled eye. So we took her up for surgery again. Standard 23 gauge ports were made. SOR was done. Inferior shallow recurrent retinal detachment was noted, but then our search for the retinal break began. We used the flute to see where the break is, but of no use. We couldn't find the causative break. We then used the help of PFCL to see if there is any sclerin, but we could still not note the break. So I'm here to present a novel technique of identifying occult retinal breaks intraoperatively. We used brilliant blue dye in 1:1 dilution via both the transscleral and the subretinal routes. For this transscleral route, we used the 26 gauge needle mounted on a 1 ml syringe in the dominant hand. The tip of the needle was applied to the globe tangentially and positioned where the depth of the SRF was greatest. The bevel was directed away from the retina to prevent iatrogenic damage, and enough dye was injected. This is a video showing the same. The needle is injected transsclerally, BBG is injected, and there you can see the plume of dye coming out into the vitreous space, and the break is at the margin of the CRA scar. For the subretinal route, you can use the commonly available cannulas, either the imported or the Indian ones. In this case, there's an inferior recurrent retinal detachment. The subretinal cannula is being used transretinally. BBG is being injected, and there is a plume coming out into the vitreous space. To delineate the break more clearly, we are using PFCL, and we can see the break at the margin of the PFCL bubble. So, occult retinal breaks form the second most important cause of recurrent retinal detachments. We can miss identifying these breaks because of various causes as enlisted here. Why is it important to identify occult retinal breaks? Because it prevents unnecessary destruction of viable retina through 360-degree laser and reduces the chances of recurrence. A subretinal BBG is particularly useful in high myopic patients. So through our literature search, we saw the description of dye exclusion technique, but all the larger studies used trypan blue. In our case, we used BBG over trypan blue because of the safer toxicity profile. The transscleral route has no unnecessary retinotomy, no destruction of more retina with laser, decreased possibility of recurrence because of the identification of break, and no requirement of subretinal cannula. But yes, there could be a possibility of hypertonic choroidal hemorrhage or a retinal hemorrhage or an iatrogenic break, but none were observed in the cases we used it in. So to conclude, BBG offers a better safety profile. Transscleral route requires no special instrument and no unnecessary drainage retinotomy. Subretinal route could be useful in high myopes with posterior detachments and significant scarring. Thank you.
Dr. Rajshekhar will be discussing.
Yeah, the search and efforts are good, but how many cases? This is the one case that you people have done, no?
Yes. So there are multiple cases that we do have multiple cases. I've personally assisted my chief operating surgeon, Dr. Mahesh Shanmugam sir, in almost 5 cases, and he's done it both ways, transclerally and transretinally, and we have not noted any particular side effect as such.
I think it requires a lot of skill, and the risk of hemorrhage is there. In case it bleeds, the whole thing. So maybe a safer way of staining and find. Basically, you're using the staining technique to find out.
Yes.
Now reaching the stain to the location is another challenge.
Yes.
So, any other comments?
In a myopic eye, I would also have my apprehensions on using the transscleral route.
Yes.
While I feel the retinal route is far more safer, but there you're creating a retinotomy.
Yes.
Then you see the unseen through the seen. something like that. So probably that might be another in case the staining works very well.
Usually, when we have used brilliant blue dye within the vitreous.
Okay.
So when you do it subretinally,
Yes.
would you do some animal experiments to study retinal toxicity, subretinal toxicities?
So in my
etc.
literature,
before, yeah.
so in my literature search, animal studies have already been done, which prove, even an ERG has been done, which proves that the toxicity profile of BBG is way more lesser than ICG, trypan blue, or even tricot. So it's there on my slide.
Okay. Okay.
Yeah.
Do you have a guard or something to stop it at the subretinal space, or how do you exactly guide? Because these are myopic eyes and the scleral thickness might be different from a regular eye.
Correct, sir. So it is mainly when we see the plume of the dye coming into the vitreous space, that is when we stop, firstly. And secondly, BBG dye per se is lesser, denser than water. So it gets flushed off from the subretinal space much more easily. So the concern of retention of the dye in the subretinal space is also much lesser. But yes, the eye should always be also in the vitreous cavity. As soon as we see the plume of dye, that's where we stop.
The next presenter is Dr. Thank you. The next presenter is Dr. Dipankar Das, and the discussant is Dr. Shobhit Chawla. Dr. Dipankar Das will be presenting on management of retinal pigment epithelium.
Good morning, everybody. Respected chairpersons, judges, and ladies and gentlemen. My innovation is mapping of retinal pigment epithelium in normal and pathology. Myself and my it's not moving. Myself and my co-author do not have any financial disclosure to make in this presentation. Well, retinal pigment epithelium is a continuous monolayer of cuboidal epithelial cells extended from margin of the optic nerve to ores serrata. We try to look the pattern of RPs in disease and well as in normal states. Now we see this is a normal retinal pigment epithelium that we have demonstrated in raw specimen in a nuclear specimen eyeball. So this hexagonality is evident here. Now what made me think curiously was these two photograph. One is a normal RP, and other within the RP there are atrophic areas in a post-chemotherapy retinoblastoma cases. Now, this objective of this presentation is to know the newer finding of retinal pigment epithelium atrophic changes in human eyes. This is institutional-based prospective study where ethics committee approval was taken, and raw specimen was studied from retinoblastoma, 17 cases post-chemotherapy out of 51 cases, choroidal melanoma in 4 cases, inflammatory cases was 7, and infectious condition was 9. Mapping were done in video mode as well as in still mode by Zeiss camera and microscope. And this is the retinoblastoma cases. You can see out of 51 cases, 17 cases of post-chemotherapy all have typical central retinal RP atrophy, which was confirmed by histopathological HND stain slides. And these are the drusen as well as the RP proliferation. And choroidal melanoma, as we know that melanoma is not sensitive to chemotherapy, so all there are naive cases do not have these 4 cases RP changes. And inflammatory cases, particularly sympathetic ophthalmia, there was a diffuse as well as discrete, and some of the areas where normal RP changes. In infectious pathology, the fungal endophthalmitis all has very severe RP changes with hemorrhage. This also a diffuse, and in rubella retinopathy, there's a normal as well as atrophic areas were seen. So definite pattern were observed in retinoblastoma. choroidal melanoma did not show atrophic change. In 4 cases, sympathetic ophthalmia, we see discrete as well as diffuse changes, and infectious cases had a severe RP loss because of delayed presentation. In conclusion, this mapping of RP showed evidence characteristics of central atrophic changes in RP from following a systemic chemotherapy in retinoblastoma. Further research is needed to determine clinical implication of this finding and to explore option for RP sparing chemotherapy. Thank you for patient hearing. I like to acknowledge SSDN Ocular Pathology Department, Ocular Oncology Department, Ocular Pathology Department, and Dr. BBCI, which is the Tata Cancer Institute at Guwahati, India. Thank you for patient hearing.
Very nice, Dr. Dipankar. And it's a good beginning, but needs to be studied more. And would be very interesting to see what are the prognostic implications of these changes and the behavior of metastasis and recurrence, especially in choroidal melanomas. That would be because most choroidal melanomas develop micro metastasis over a 7-year period. So this would be a very interesting to see whether the response, more atrophy, causes less micrometastasis or not.
Yes, sir. Thank you so much for your feedback, sir.
Thank you, sir.
Thank you.
Now I would like to invite Dr. Anand Parthasarathy to present his talk on Look Closer, Go Deeper. So if he's not there, then we'll move to the next presenter, Dr. Prasanna Venkatesh, who will be presenting on 3D printing ophthalmology related models, and Dr. Kumar J. Doctor will be the discussant.
Good morning, everyone. So mine is going into pedagogy, that is basic sciences. So we have inculcated 3D printing to actually print basic structures that you can see me holding in my hand, such as normal anatomical structures. So for me, when I was a resident or when I was trying to imagine something, structures which are very cognitively difficult to understand, like the intracranial structures like the circle of Willis, cavernous sinus, which we don't tend to dissect in our medical curriculum. So how can we work on these kind of structures to facilitate critical thinking and coping skills so that the learning is much more fast forwarded rather than a lot of imagination and theoretical cognitive frameworks. So what we started doing was we did do a lot of augmented reality work, but we felt nothing like real touch and sensation. As you can see the models here, I'll be showing you my cavernous sinus models as well. So these are models which we actually printed, which I'll be circulating. So this, my dear friends, gives you the real models of touch and print. So when we browsed the literature, there was nothing which was actually printed in 3D. 3D printing was used for many other innovations in ophthalmology, but a simple basic science such as toys and puzzles that the children used to play to improve the intellectual language was never applied in ophthalmology for basic sciences. So we went ahead, we sat the anatomy, we read the anatomy in Cunningham's, we made sure we did the 3D orientation, we use the Cura software, because in 3D printing, when you are printing a very, very tiny structure, it's very difficult. It tends to easily break. So we started collecting, we started meticulously planning these structures so that they don't break when we print in a form of a toys. Even the eyeball model has been printed. Ajay, can you give me the eyeball model? So we use Fab Excel and Fab Plus printer depending on the structures. The cavernous sinus was slightly printed larger and the polylactic acid material was used, and we also printed our own eyeball model. I'll just tell you why this is different from the models that is currently available in the market. Actually, you can see that we can also color the models accordingly to the whatever color that we want them to represent, like the circle of Willis that you see, which is red in color, and the cavernous sinus, which is blue in color, along with the transverse and sigmoid sinuses. And we also upgraded our model to the second protocol. The first model was more of horizontal. This is the second prototype circle of Willis model, which you can see the endings and the bendings are much better compared to the other models. And then we also had our own eyeball model where we had the retina with thermopolyurethane. You can see it squeezes. The sclera and the choroid is more rigid with thermopolyurethane. And this squeezes so that you can use any fundus image and you can make sure you can train the patients in laser. You can show different pathologies, like just like an automobile engineer. Can we also have the eye dissected in different structures in multiple colors, which is a simple and basic idea, but it is also very, very cost effective, my dear friends, which literature has never reported. So you can start collecting your own eyeball models with different kind of color funders, autofluorescence, infrared, and have your own toolkit printed so that this may help the neophytes and the beginners to cognitively orient into the structures as well. And you can see that we have launched this in our startup, and this is openly accessible in our website www.org.in, and it is very cost effective. It is 200, 200 and 1000 for all the three models, and it takes just a day to print. So this, my dear friends, I feel will be the future of ophthalmic pedagogy. So we have also extensively working on a fully fledged puzzle model where can we have all the cranial structures like a puzzle and have it as a product so that we can sell it so that the neophytes can actually assemble the puzzles just like an engineer and can have no blind spot regarding the neuro-ophthalmology, which will be a much better way and a much simpler way of learning and teaching and counseling. Thank you.
Very good idea, very good thought process, very impressive work that you've done. And I'm also impressed that your cost effectiveness is very, very good. So this is different from the other 3D learning that you were showing, right?
Yes, sir. When we started doing, I'm basically into augmented reality, sir. I do a lot of apps in the phone.
Yeah.
So when we started doing a lot of applications and when we did a lot of road shows, the feedback that we started getting from the teachers in ophthalmology is, yes, technology is good, but can you give me something that I can really feel and touch? Because in augmented reality, it was more virtual and more tech savvy. So when the senior teachers told that they wanted something to really feel in reality, so we shifted our idea towards reality so that we started printing models, sir. So once we made the template, now if anybody wants to get a model, it's easily done.
So to print one, it takes, you said it takes a day?
Yes.
And
the
then
eyeball takes 36 hours, sir, 1.5 days. The cavernous sinus takes around 12 hours. The circle of Willis takes 15 hours, sir.
So you created your own lab to do all this, or
Yes,
you outsourced
we have our
it?
own startup, sir. I created my own startup.
Very
It's
good.
called Mahatma Center of Moving Images Private Limited, and we have registered the startup. And this is also patent also has been filed for this provisional specifications.
Very good. Congratulations.
Yeah, it's www.mcma.in is the link. If any one of the people type here, you can see all that. www.mcma.in, Mahatma Center of Moving Images. Yes.
Congratulations.
Thank you, sir.
All the
Thank you.
best.
This is a wonderful thing. Would you start labeling them? Is it possible to label them in black ink or something?
Yes, sir. Just like the Batman and Superman toys that come in the market, now we are developing a package, and it will all be allotted like this. And we are developing a cursor so that they can click on it with a simple, like a toothpick, anterior communicating artery, anterior cerebral artery, internal carotid artery. So in Viva OC or in exams tomorrow, just like how the skull is given and told to point out the foramen ovale, foramen rotundum, the teachers can actually give them a model like this and can tell them, can you point out the circle of Willis structures? It can all be done in a much easier
For
way.
educational purposes, would you label them and market them?
So we have labeled them, sir, because of the portability and other things. I just brought all the three models. The packaging is there, just like a toy that we all buy when we were kids, that Superman and Batman. Exactly, we have packaged them like that along with the labels. It's like a toothpick with the heading on top, just like the candles that we use for the birthday. So the labeling is also worked out.
Great. That will be very nice.
Just last question. So to the best of my knowledge, I think the anatomy bones are already available, which are 3D printed, and they are all labeled, and these are available in the market.
So bones was relatively easier to print because in 3D printing, the fragility of the structure is what makes it more difficult when we print structures like this. In the first prototype circle of Willis model, we were not able to crack it because as we go towards the periphery, the edges were getting more thinned and the models were breaking. So these kind of models were very difficult to print because these are all veins and arteries and eyeball. Bones are relatively easier to print. So the coding and the anatomy learning had to be more precise when printing arteries and veins. Sir, which is more difficult.
A little move forward, the world is moving towards 3D printing of the corneas.
So 3D printing of the cornea has two parts, sir. One is bioprinting is something that is the real frontier. So we are slowly taking baby steps towards that also.
Correct.
So this is something that we have started. At the end, we would definitely like to end up with bioprinting, sir. Yeah.
Congratulations.
Thank you, sir. Thank you.
Dr. Prasanna, you can collect your certificate from Dr.
The next presenter is Dr. Subhendu Boral Kumar on micro VFC. Discuss it.
Micro.
Very good morning. Video, please.
Micro VFC, a simple indigenous new tool to access subretinal space in a controlled way. VFC, that is viscous fluid control, is commonly used in vitreoretinal surgery to inject silicone oil within vitreous cavity or to extract it in a faster way. We developed a simple indigenous modified VFC to gain access to subretinal space in a controlled way. We have removed the plunger, cut the rubber cap of the plunger of a 1 ml syringe. This cut rubber cap was fitted inside an empty 1 ml tuberculin syringe. Its end was fitted with the tubings of VFC of vitrectomy machine. Now VFC mode was activated. Attaching an either 38 gauge or 41 gauge subretinal needle to the syringe to extract the retained submacular PFCL bubbles or to deliver precise dose of subretinal drugs like RTPA for subretinal hematoma in a controlled way. Here the cut rubber tip of the plunger can move smoothly within the 1 ml syringe during injection or extraction mode of the VFC. We named it Micro VFC. Firstly, the practical application for extracting the subretinal retained PFCL bubbles. Here it's a case of status post-vitreoretinal surgery with a retained subfoveal PFCL bubble with best corrected visual acuity 2200. I used our micro VFC using metallic tip 41 gauge cannula. After extracting the silicone oil, I went ahead with this micro VFC. I directly pierced the fovea with the metallic tip and made the extraction mode on with around 300 to 400 psi to aspirate out the PFCL droplet. Fluid air exchange was completed. Post-op best corrected visual acuity was 2080 with complete absence of subfoveal PFCL bubble. In our second case, post-surgery for giant retinal tear, there was a large bubble of submacular PFCL threatening fovea with best corrected visual acuity 2060. After removing silicone oil, I used this micro VFC with 41 gauge metallic tip cannula to remove the submacular PFCL bubble. Using viscous fluid extraction mode with 400 psi extraction pressure, PFCL bubble was extracted completely. Post-operatively best corrected visual acuity improved to 2040 with complete absence of submacular PFCL bubble. I also use this micro VFC for delivering drugs in subretinal space. Like in this case of post-PCV massive submacular hemorrhage with best corrected visual acuity, hand movement close to face. Here I used our VFC with 38 gauge non-metallic cannula for injecting recombinant tissue plasminogen activators 0.05 cc, that is 50 microgram, directly into the subretinal space through a mostly elevated area just outside the macula for clot lysis. The subretinal injection of RTPA was completed in a very controlled way. Again, I have used combination of anti-VEGF ranibizumab injection 0.05 ml and filtered air 0.03 cc and injected slowly in subretinal space outside the macula. Then I completed fluid air exchange and used sulfur hexafluoride gas tamponade. After 3 weeks, best corrected visual acuity improved to 20/120, significant reduction of submacular hemorrhage with CNVM remnant only. So this indigenous micro VFC can be used for both extracting subretinal PFCL bubble or delivering the drug subretinally in an exact dose as well as in a very controlled way. It can also be used for further transduction of subretinal gene therapy. Thank you.
Yes. Now, I think you have noticed I have injected just outside the inferior vascular arcade. That's why to avoid you have to go as far as away from the phobia, because you are actually increasing the subretinal volume of the drug. So that will, the volume of the subretinal space, it will increase, and it will find its weakest part to give way. So phobia is the thinnest part of the retina, so it can cause blowout rupture of the fovea that cause iatrogenic macular formation. That's why you have to go away from the phobia. Yes. And that mistakenly you cannot give the more amount of drug, because you have already measured it, that 0.05 ml, exact that volume. And I am injecting subretinal TPA, subretinal anti-VEGF, as well as air, 3 injections, so triple. That is the that's, you have to be very cautious. So yeah, unfortunately, like, you should not give more amount of any kind of medicine in subretinal space. Like, you can do it manually, or you can use the regular VFC, but it can cause sudden collapse of the that subretinal space, that can cause unnecessary damage to the RP and as well as photoreceptor. Thank you.
Thank you, doctor. You can collect your certificate. Next, I would like to invite Dr. Hirika to present on AIOC, a perfect surgical digi logbook for every resident. Dr. Vinod Kumar Arora and Dr. Thomas Cherin are the discussant.
So I'll be talking about AIOC, a perfect surgical digi logbook. So let's all go back to our first day of OT, our first cataract surgery. I'm sure all of us will be really anxious, adrenaline rush, and a lot of trembling in the hand. So you would also fear what your trainer would think about you after the surgery. You need more practice. Your tunnel wasn't correct. You're putting too much pressure on the globe. You need more wet lab practice. So yes, obviously, but the important question is, how did we perfect those surgical steps and tackle all our complications? So as a first year resident, I was told by my mentor to maintain a logbook. So I wanted to do it using my iPad because it made things more easy. So which is equivalent to an Excel sheet. I use the numbers app wherein I used to enter all the patient demographic details and the details of the surgery, what cataract grading, the pre-op vision, the post-op vision, and the complications, and intra post-op complications, the post-op vision, and what were the steps that I assisted, the steps the trainer assisted me for, and who assisted me. So initially I was having a lot of complications, and slowly when I started using the logbook, I realized that I was actually improving because I could review back on what was happening, what was a step that I really need to work on. So later my complication rates reduced, and it really helped me grow in my surgeries. And also we used to do the Oscar grading, the ICO ophthalmology Oscar grading, wherein we used to print the sheets and we used to ask our trainer to grade us after whoever has looked at the trainer who looked at the surgery when we were operating. So it covers from the first step of the SICS, from the draping to the scleral the cauterization, to the tunnel, to the rhexis, to the nucleus extraction, to the lens insertion, and to overall speed, fluidity of and they used to also comment and give us a score. So it was a tedious job overall. So this hackathon which happened in Arvind Eye Hospital, I found Scrubbook, which is so you can see here how Scrubbook works. So Scrubbook is a web page app wherein the trainee can register, log in, and add all the patient details. It can be the demographic details, to the name, the age, and all the date of the surgery, place of the surgery, and all the details required, complications, pre-op vision, post-op vision, astigmatism. He can also add the surgical link, the steps assisted, and any comments by the trainer. So So also the trainer can log in and he will have the trainee ID, and he can use the trainer login to actually grade the trainee, whoever he's added the employee ID of, and he can grade the trainee according to the video link, or if he's seen it with the Oscar grading, and then the trainee can actually see what the trainer had to grade him accordingly. So this was a very early stage of the app that we are working on. So it is a handy go-to app for every resident, which can be used as a digital surgical logbook. It can store patient data, it can record and can be searched by the trainee at any time, at any place, and all complications can be reviewed at once. The complications can be moderated by the trainer. It can be reviewed on the app, and then also you can see the Oscar grading. I'm working on the future prospects of introducing statistics for all complications to insert an alert notification on exceeding complication limit or recurring complications, then surgical lessons by experts for complication management, and taking it beyond cataract surgery and for other specialities, and to hire expert surgeon to advise to grade the trainee cataract surgeries. So concluding, I would like to say it's a web page app which can be used by residents, fellow consultants, anybody who wants to actually have want to review the surgeries. So it is available now. You can all check it if you want to. Thank you.
I think it's a good idea to review yourself, and it improves our working also, and we know how much we are progressing. I think it's a good idea, but it's available easily.
Yes, sir. You can use it.
Anybody can use it.
Yes, sir. It's the web page app. I'm working on the app. As of now, it's a web page app. It's not an app directly. You have to Google it. So you can use the link over here, but the app is, I'm working on it. So
And
it will be
I think it can be customized by the resident himself or herself.
Yes, sir. Yes, sir. So it is mainly about how your you can also ask your trainer to see your video. You can put the video link also to review for the trainer.
So it provides a common platform to trainee
Yes,
and trainer. Right.
Hirika, it's an excellent tool. One or two suggestions.
Yes, sir.
Your alerts mode, that is something very good. But then your consultant or your trainer should also be able to insert some warning signals.
Yes, sir.
If you as a trainee is having some complications which he wants to alert you, then maybe when you open that or when you go into that case, that particular insert should also pop up.
Yes, sir. As of now, he can add comments. So we'll surely make it like an alert option or something. Thanks.
Thank you, Dr. Hirika. You can collect your certificate. And the next presenter is Dr. Ankit Agarwal on low-cost wide-field OCT. And discussant will be Dr. Anirudh Maiti.
Good morning, everyone. Sorry. Yeah. The topic is low cost wide field OCT. I don't have any financial interest in this. OCT has proven to be a very useful tool for screening and diagnosis of various macular and optic disc disorders. We all use OCT routinely in our OPD setups for diagnosing pre-cataract patients, for ARMD, for DME, etc. The most commonly used OCTs in the current clinical practices are spectral domain OCTs, and which are traditionally have a limitation of lesser scan area as compared to a newer generation OCTs of Swepsos or newer generation spectral domain OCTs. The OCTs which I have used previously have a scan area of 6 mm or 9 mm at the most at the macular area, where SS OCTs have 12 mm or even up to 18 mm now OCTs have come. Thus, the lesion extensions of edema, SRFs, CSR, etc., which may be present in the perimacular area, may be missed in a single macular scan. Many a times the OCTs are done by our assistants, not by the doctors themselves. So we may have to ask assistants again and again to do the peripheral scan to show the extent of the CSR, so that we may rule it out that it is not a shallow RD. To overcome this, we propose a low-cost technique to increase the scan length, thus be able to screen most of the area within the vascular arcades in a single scan. Thus, we did a study where 10 patients with various indications for OCT screening, which included diabetic retinopathy, preoperative screening for cataract surgery, ARMD, CME, and CSR were selected. The machine which I used was a Topcon Maestro 1. The default scan length in this OCT is 6 millimeters in the radial configuration for macular area, and the macular OCT was performed. The image thus obtained was analyzed. Now, another OCT was performed in the same configuration, but with the patient wearing a +20 diopter aspheric glasses. The image thus obtained was analyzed and compared with the images obtained without wearing the spectacles. These are the glasses which we use for the patient, this is how the patient sits in front of the OCT wearing the glasses. The scan length in the OCTs done with the spectacles was about 1.5 times larger than the scan length without the spectacles. The distance from the optic disc to fovea is about 4 to 4.5 millimeters in normal individuals. Thus, the scan with spectacles covered the entire area between the temporal border of the optic disc and the vascular arcade in a single scan. Now, this is the smaller area is the scan covered without the glasses, and the larger area is the scan covered when the glasses were put. Mind you, this is for a normal individual. In a myopic individual and a highly hypermetropic individual, the area covered will be different because of the optics will change. Now, this is how it will look. With +20 diopter spectacles, there is a larger scan area, whereas without the spectacles, only the small box area will be covered, which is showing in the lower screen. In a case of a right eye BRVO, we can see that the extent of the BRVO is till much peripheral area than shown with just the without spectacles. In a case of NPDR, we can see there are some hard exudate lesions present outside the scan area of a without a spectacle scan. Now, this is how the optics work. The right rays from a wider region are converged by +20 diopter lens, thus giving a wide field OCT image. The patients who underwent OCT with +20 diopter spectacles had an increased scan length as compared to those without spectacles. This helps in screening of patients of diabetic retinopathy, BRVO, preoperative immature cataract screening, ARMD, CSI, etc. for extent of edema. The limitations are that the system has only been tested on one OCT. However, basic optics of any OCT machine are same, so it should work with most OCT machines. The parameters like macular thickness, volume, etc., which are assessed by the OCT software, will not be consistent since the software is not configured for using an extra lens. This innovation helps in increasing the field of imaging and thus can capture perimacular areas which might have been missed earlier. The cost of this lens is only 1,000 rupees approximately, so it's a very economical project. Thank you.
Dr. Ankit, it's a nice, innovative way of doing the things. But what is the clinical implication? Because most of the things what we want to see in an OCT is the central macula.
Yes, sir.
So what extra information do you get by having this wide field OCT? Like in a DME, as you mentioned, it's the hard exudate and near the arcade. But how does it help in my treatment?
So it doesn't really help that much in the treatment, but we can actually record it, it's present, and later on, the DME is a progressive disease. The DME is not going to resolve usually. Most of the patients are who are diabetics, it keeps progressing. So when we see the patient again at a later stage, we can know that there was some peripheral hard exudates were present, which have now it has increased and the macular area has now involved again. So secondly, sir, in CSR, the extent of CSR is very important. A lot of times in a single scan, if it's a huge CSR, we might even miss the peripheral extent of the CSR. We might miss some PEDs which are present outside the scan area. So this will show that those PEDs or the extent of the CSR can be shown. If it's a shallow RD, mimicking a CSR, so we might be able to know that it's not a CSR, it's a shallow RD because it's going outside the arcades. Now we have to properly examine using IDO again to see how far it is, if it's in break or there or not.
I think in the peripheral PCV, this can be used. Obviously,
yes,
the field needs to be enlarged more.
Yes.
When you are using the spectacles, does it reduces the signal strength?
Because yes, slightly reducing the signal strength, sir. But if the cornea and the lens are relatively clear, then we are getting good images. But yes, if lens is cloudy, then the signal strength is slightly reduced.
Thank you.
No, I want to defend you by telling that it will be very useful in posterior uveitis.
Thank you, sir.
Thank you, Dr. Ankit. You can collect your certificate.
The next presenter is Dr. Pradeep Kumar. He is going to present on retrobulbar dexamethasone and triamcinolone mixture in optic neuritis. The discussant will be Dr. Rashmin Gandhi.
Yeah. A very good morning to everyone. I'll be talking about injecting a mixture of dexamethasone and triamcinolone in the retrobulbar space in cases of optic neuritis. So most of our conventional wisdom comes from optic neuritis treatment trial, which says that if we give IVMP, it hastens the visual recovery but does not affect the final visual outcome. And giving oral steroids at the routine dosage may actually be more harmful to the final visual outcome. So this is your classic optic neuritis patient. And these patients generally do not have any comorbidities. You can safely give them IVMP. And most of the Indian population does not have multiple sclerosis, and good visual recovery is generally seen after the first episode. But the problem was appreciated when we were working in tertiary care hospital, and we started getting lots of patients who had comorbidities which prevented them from receiving IV methylprednisolone. They were walking in from non-neurological wards like rheumatology patients, even from endocrine and nephrology department, where we saw an overlap between the optic neuritis and NAION spectrum, where even a 70-year-old patient proved to be a confirmed case of optic neuritis on serology. And we were also getting atypical optic neuritis patients from neurology ward like NMO and MOG positive patients. So we had patients who were not candidates for IVMP. There was existing evidence that the peribulbar and retroorbital space can be used for delivering drugs. This stemmed from the COVID pandemic associated orbital mucormycosis, where we were injecting antifungals in these spaces. The peribulbar space was not very ideal for injecting steroids because the concentration of drug will reduce by R⁴ factor. So we chose the retrobulbar space as the ideal route. And which drug to use? So we had dexamethasone, which was faster acting, but within 48 to 72 hours, it is disappearing from the extracellular space, and the implants could not reach that space, whereas the triamcinolone was slightly slower acting. So we decided to make a cocktail of the two in a 2 ml mixture and use it. So these were our first 3 cases where we had a nephrotic syndrome patient who was already having secondary diabetes mellitus, walked in with right eye vision of 3/60. We tried this technique, and within 3 days, visual recovered to 6/12. Final BCV was 6/9. We had another breastfeeding women who had recovered from preeclampsia, had recent malignant hypertension, could not be given IVMP. With 660 vision, she improved to 6/9 in 24 hours with final visual acuity of 6/6. And lastly, we had a lupus nephritis case. In this case, there was again 1/60 vision, which improved to 6/12 with this technique. We became bolder and tried it in our atypical optic neuritis patient. Till now, we have used it in 2 patients. First was a 17-year-old boy. He had his board exams going and he could not be admitted for administering IVMP. And he insisted that you treat me on OPD basis only. And luckily for us, the patient recovered to 6/9 in 24 hours with final visual acuity of 6/6. And another MOG positive patient, right eye had already undergone optic atrophy. The left eye had a presenting vision of 4/60. We tried this and the vision recovered. This patient did not want to go through another IVMP cycle. So we huddled up with our neurologist to find out that what was happening. They said that the bolus dexamethasone was saturating the nuclear RNAs and was triggering an anti-inflammatory spike sufficient to break the cascade. They questioned the role of triamcinolone. So we sat down and we decided that what we need to do is study about this with all the serological, CSF and neurological workup for each and every case. So this is the study we have designed. Till now, we have had 7 patients in each arm, 12 patients we require to reach sample adequacy, and the results we'll come out with subsequently. Thank you so much. And I'm so pleased that Dr. Rashmin is here. He was the first person to take our class in FMC long back on optic neuritis.
So it's a good thought. It has been tried in the past that can you avoid systemic IVMP altogether, and before MRI or before serological test, this was probably even more popular. My apprehension is that if at all, if you say that this is proven, the indication for this would be very limited because MOG or NMO, they are all the diseases which are manifesting in optic nerve, but these are not optic nerve disease. I mean,
Very
it's just
good.
optic nerve is one of the organs which is reacting to something which is circulating in the blood.
Very true.
So, a local treatment for a systemic disease is something which may not work out. In fact, all these antibody mediated disorders, optic nerve effect is your first signal that it might now go and attack spine or somewhere else, and it becomes an emergency in a lot of these patients to say IV not only IV steroids but immunosuppressives or even plasmapheresis. So you might have to initially, if it first is to prove efficacy that this is what worked and nothing else, choose very judiciously and see if that is get approved, and if you're able to publish it, then it will be a good value add. But I think road ahead is a little longer.
Thank you so much, sir. Thank you for the comment.
Thank you, Dr. Pradeep. You can collect your certificate.
Next, we request Dr. Anand Parthasarathy to present his study on intraoperative hacks for anterior lamellar keratoplasty.
Good morning, everyone. Can I have my slides? Okay. Video as well. So the ideas for this came when we described two intraoperative hacks to help improve the good results in a lot of these patients. So the reason this is predominantly for anterior lamellar keratoplasties, and the reason that we need to make sure that we get good results is that over a period of time we have found that if you're able to mark the cone, and this is important for deciding the size of the trephine, and the dilated pupil actually gives the extent of the ectatic cornea, both the irregular epithelium, which is a very consistent finding, and the altered contour, along with of course the iron deposition ring that we know about, seen at high magnification. So what we do is just normally for lamellar keratoplasties, you do not dilate the pupils. But in this patient, we actually put drops and dilate the pupil. What that gives you is actually the extent of the keratoconus. What this helps is that when you're actually operating, you select the trephine to include all the cone. Now, the estimation, if you underestimate what is the risk is that you would end up with a recurrence at the margin of the graft. The second small hack that we've started doing is a small bubble, which is basically important to make sure you have the big bubble, and this will help to improve the success of the big bubble technique in lamellar keratoplasty. So this is a big bubble injection. You've got the big bubble now. You put a small bubble in the anterior chamber. This actually goes around to tell you the extent of the big bubble, and you can then confidently go and release the big bubble. With the release of the big bubble, you can see the small bubble coming in. This actually helps to make sure you get the Descemet's bearing. Thank you so much.
Since Dr. Swapna Noyer is not there, judges can ask questions. Any?
I informed the scientific committee that we had changed the topic for intraoperative hacks from the intraoperative OCT.
It's not mentioned here.
Okay, I had informed them.
Can we evaluate?
I'll just ask. You can evaluate, sir. I'll just ask Dr. Chitra Ramurthy.
I had informed the scientific committee and Dr. Grover.
When was it?
Yesterday.
No, but this is with the ARC.
Okay, I have not mailed her. I had mailed the China because the mail came from the scientific committee.
Fine, sir. So you can collect your certificate. I request Dr. Kumar Doctor to hand over the certificate to him. It's just a name, sir. It doesn't have it. Next, I would invite Dr. Narendra Singh Verma to talk on manual image guided system.
So I present to you manual image guided system. In last 3 years, we developed this topographer, which is having multiple apps. It's not going forward. Not going forwards. So, okay. There are different methods for precise axis alignment of the toric lens. The common method is manual marking. It is economical but 3-step method, so it is tedious and there are chances of error due to cyclotorsion, head tilt, and sometime during surgery, the preoperative mark smudging or wipe out of the marks can occur, causing error. So the best method presently available are image guided system. It is single step method, so it's easy and eliminate all the error, but it is very expensive. So by mixing and matching these two systems, we developed manual image guided system. In this method, preoperative marking of 2 reference points, 0 and 180 degrees is not required. So no preoperative markings. Surgeon has to select 2 limbal structure on the topography picture, which are prominent, and they act as the reference point. During surgery, he will mark 2 reference points, these 2 reference points, he will identify on the patient eye and the topography picture, and he'll mark manually just before the operation, just before putting the rotation of the IOL. So the marking is done at the time of rotation of the IOL, so there are no chances of smudging or wipe out of the marks, and it is based on the principle of image guided system, so it eliminates the error due to cyclotorsion and head tilt. Let's see how it works. Volume.
Alternative to existing solutions. It is an LED-based anterior surface topographer which analyzes 600 data points in a 9mm central corneal zone. A single capture provides us with all the required data which is summarized on a single screen. It provides keratometry in 3, 5 and 7mm zones, axial heat map, bite to bite, etc. There are 4 basic steps. Step 1. Capture topography picture. The system automatically marks the steep axis. Step 2. Enter site of incision and incision SIA. The system automatically marks axis of alignment. Step 3. Identify and mark 2 landmark points. The system will mark their position in degrees. Step 4. Manually mark 2 landmark points on the patient's eye and use them as reference to mark axis of alignment. Demonstration. Step 1. Marking of steep axis. Capture a topography picture. System has automatically marked steep axis on this topography picture. Step 2. Marking of axis of alignment. The system has direct access to Barrett Universal 2 and Barrett Toric calculator. Press the calculator icon and net astigmatism will be displayed. Now enter site of incision and incision SIA and press the calculator icon again. This table displays net astigmatism if site of incision is changed in a 40-degree range. The system has automatically marked the axis of alignment on the topography picture. Step 3. Identification and marking of 2 landmark points. The system enhances the topography picture to make limbal structures more prominent. In this topography picture, the surgeon has to select 2 prominent limbal structures or blood vessels. Mark them by touching the screen and it will automatically mark their axis in degrees. Step 4. Manual marking of landmark points on the patient's eye by comparing the final topography picture with microscope view. Use the axis markings as reference to mark axis of alignment of toric lens. Demonstration of toric lens axis alignment. Left eye keratometry of this patient shows 1.5 diopter astigmatism in 132 degrees in 3mm zone. Press the calculator icon. Net astigmatism will be displayed directly from Barrett toric calculator. It is 1.1 diopter in 145 degrees in this case. Enter SIA value, which is 0.3 in this case. The axis of alignment will be displayed automatically, which is at 147 degrees in this case. Press the pencil icon to enter biometry data, axial length, ACD, and lens thickness. The axis of alignment at 147 degrees is displayed as a green line, and site of incision at 136 degrees in the form of a pink highlighted area. Identify 2 prominent limbal structures. Click on it. The system will display their axis. It is 17 and 50 degrees in this case. Save the picture, rotate it as needed, and use it intraoperatively to identify landmark points under microscope. Here, I am making 2 landmark points at 17 and 50 degrees on the patient's eye. Hold the degree gauge and align it with the markings. Now mark the site of incision, which is at 136 degrees. After lens implantation and viscoelastic removal, bring the degree gauge again to mark axis of alignment on the limbus at 145 degrees using 17 and 50 degree landmark points as reference. You can also mark the axis of alignment on the cornea. Finally, align the toric lens axis with the corneal markings.
So thank you for your kind attention.
So I think that's an excellent innovation, but I think you need to move a little forward where actually you do away with the markings, because a lot of these times when you take the patient matching with the the picture on the topographer and matching on the microscope, I think that could be sometimes be challenging.
So we are incorporating the SDR mode. In SDR mode, because blood vessels are not visible because there's reflex of the sclera. So SDR mode will give you better picture. So all the structure will be seen prominently. And we are also developing P2 with the infrared. So it will tell you the TK directly and the net astigmatism from the Barrett. It is directly having access to the Barrett. You need not to do anything. You have to just switch on your hotspot of the mobile, and it is directly feed all the data and give net astigmatism within seconds. What is the net astigmatism from Barrett and what will be the TK?
No, but actually this is not estimating the posterior corneal surface. This is not a Shemflo based.
Presently it is there. Presently entry is there. We are also developing this SDR mode. So the prominent blood vessel will be more prominent, and P2. By P2 will...
No, but then you don't get a true K on this.
So if we will get the P2, P1 and P2, then the difference between this P1 and P2 will give us 2K. And the net astigmatism directly we are getting from the Barrett. It is directly access to the Barrett. We need not to fill anything. We need not to go the chart. Just press the button. It will tell you this is your K1, K2, anterior surface, and P2. This net astigmatism from Barrett will be this one. So you can counsel your patient. So just doing a topography, you can find if oblique astigmatism is there. So whether 1.1, how much will be the net astigmatism, you can directly get from here. So need not to fill all the forms and see what will be the net astigmatism.
Okay, thank you.
Thank you, Doctor. I request Dr. Sonu Goyal, sir, to hand over the certificate to Dr. Narendra Singh. My sincere thanks to all the presenters and judges for taking time and judging. Thank you.